Everybody, we're going to talk today about sepsis, vasopressors, and shock. This stems from our recent introduction of a sepsis protocol into our current library protocols. I wanted to go over a little bit about the importance of recognizing sepsis and aggressively treating it, because it is a very deadly disease. If it doesn't kill you, it leaves you permanently disabled in a lot of cases. And it's something that I think gets underemphasized because of all the trauma and STEMIs and strokes and everything. And this one isn't as obvious to recognize sometimes, which makes it even more important that we learn how to identify it and start treatment on it. And then I'm going to go over vasopressors, which of course we're introducing a new vasopressor to our protocols in norepinephrine, Levophed. So I want to go over all our basic vasopressors, because you may end up transporting a patient that's on a vasopressor that's not currently in our protocol. So I kind of want to go over the basics of all our vasopressors. And then lastly, we're going to go over the different kind of shocks and how you're going to treat them, because this is good review for everybody. And then we're going to tie up all of it in a couple of case scenarios. So we'll go ahead and start talking about sepsis. So what is sepsis? Sepsis is a life-threatening, dysregulated response, usually triggered by a systemic infection, okay? There's several things that aren't quite completely understood about sepsis as far as what causes everything to go bad so much, but it could be from immune abnormalities by the invading bacteria and the pathogens. There may also be a component where tissue damage that causes inflammation and immunosuppression that causes a completely dysregulated response. Eventually, all of this dysregulation can end up leading to organ failure, dysfunction, or death, okay? So some of the causes, these are the three most common causes: pneumonia, intra-abdominal infections, and UTIs. And of course, right now, you know, we're in our winter time right now. Pneumonia is out there. A lot of people say they've had the pneumonia vaccine. That's great for streptococcal bacteria. However, there are other bacteria that can cause pneumonia, and we need to keep that in mind. The pneumonia vaccine does not protect you from pneumonia, period. So important to remember that. Some of the stats on sepsis: about 850,000 ED visits a year, okay? 25% of cases, 25% of the cases result in death. 25%, so that's a pretty significant number. Costs $17 billion a year to treat sepsis and the complications that are associated with it. It's the leading cause of 30-day hospital readmissions, more so than STEMIs, CHF, and COPD. So think about that for a second. That's pretty significant, okay? It's been shown aggressive treatment early on does improve outcomes. The problem with this is it's extremely difficult to sometimes recognize that you have a septic patient, and sometimes it's even harder to move into action on these patients on what do we need to do. So EMS encounters for septic patients, roughly 3.3 per 100 patients in the EMS system are sepsis, severe sepsis. Only 18 to 21% of septic patients are suspected by the EMS provider, so that's less than 25%. Do we recognize, hey, this patient might have sepsis? We only give fluid to about 50% of these patients, and of all the things that we can do, we can't do a whole bunch, but pre-hospital fluid resuscitation has been associated with shorter hospital stays, okay? So this is something, you know, much like when you're bringing in a STEMI, yeah, you get them to the cath lab and they do great. You bring in a stroke, you give TPA, or we get interventional procedures done, and you give the patient a really good chance of having a good outcome. Sepsis is no different. If you can start treatment early on, you can recognize it first of all, and you can start treatment early on, you have a really good chance these patients are going to do very well. They're going to recover completely, and they're going to walk away with all their organs intact and not have any major comorbidities, okay? But the problem is there's no easy test, right? There's no neurological exam that you can do that helps you identify sepsis. There's no EKG that shows you, oh, this patient's having a STEMI. We have to think about it. We have to investigate a little bit. We have to get a good history and physical to really suspect it and to activate and start treatment on it. But it's one thing about sepsis has been shown: aggressive early treatment is the key to helping these folks survive and have a good outcome. So what can we do as EMS providers, right? A lot of sepsis identification, a lot of times is based on advanced testing, which obviously we can't do in the back of an ambulance or in the back of a helicopter, but the identification is all in the history and the physical, okay, and the vital signs. So we need to identify this early on, okay? The earlier we can identify it, since we're the first people that come into contact with these patients, we are probably the best people to try to get the ball rolling on this. So early identification by getting a good history and physical, okay? And not just, okay, what's going on today? You're having a cough, okay, let's load them up. Find out a little bit more information, okay? Get a full set of vitals and identify your risk factors for sepsis based on the protocol that I'm gonna go over here in the next slide. The next thing we can do is start fluid resuscitation. Okay, these patients, once they get to the hospital and they're identified to have sepsis, they're required to get 30 milliliters per kilogram of fluid. Now, that's a lot of fluid, okay? You got a 100 kilogram patient, that's 3 liters. So if we're able to at least start 1 liter and get a liter in, and the thing is they're timed on it. They have like 3 hours to get all this fluid in, plus start antibiotics, plus get a whole slew of labs and pinpoint exactly where the sepsis is coming from. So if we're able to at least get a liter in, not only is that gonna help the patient probably with because these patients are probably gonna be hypotensive, it's gonna help their outcome, it also helps our counterparts in the hospital, okay, because they're gonna have to continue treatment. So make sure you start fluids and be aggressive. It's okay, like I said, they need 30 milliliters per kilogram. We don't have, most of our transports aren't that long that you're gonna get that much fluid in them. But if you can slam a liter in them, that helps. That's gonna help your patient, that's gonna probably help stabilize them, and it helps the patient's overall outcome, okay? And always report how much fluid you're giving. So if you got a liter in, let's say you got 2 liters in, you started 2 large bore IVs and you started 2 liters, you got 2 liters in on them, make sure you report it to the facility that you're transporting to. So that way they know where they stand as far as how close are we to hitting that 30 milliliters per kilogram goal, okay? If you do have a long transport, let's say you have for some reason you're picking up a patient from home or from a nursing home and you have a 30-minute transport to your emergency room or to wherever you're going, start fluids aggressively. And in our protocol, we're gonna introduce norepinephrine to those patients that after we give them a liter fluid, they're remaining hypotensive. We need to work on getting their blood pressure up. We're gonna start using norepinephrine and move away from dopamine use. And then the last thing, and this is the big part of our protocol, this is what it's all about, alert the receiving facility. If you were taking a STEMI, what are you gonna do? You're gonna call the facility or you're gonna Pulsera it. If you're taking a stroke, you're gonna call ahead of time, you're gonna let them know, hey, I'm bringing in a code stroke, or Pulsera it. Pulsera is also going to have a sepsis alert on their app eventually. I think it's already out. I don't think it's activated on any of ours, but hopefully we can transition to using that just like we can use it for STEMIs and strokes, because that helps the hospital folks recognize that they've done all the measurements that they need to do. So if we have that, great. If you don't, call the facility and let them know I'm bringing in a potential sepsis patient here, okay? It's been shown if we're able to identify early on and activate it to the receiving facility, it helps patient outcomes because there's shorter delays to them getting antibiotics, they get their fluid resuscitation, and they get taken care of a lot more aggressively, okay? Can't tell you how important it is that we do this, because just like when you take a STEMI patient in, what happens? You usually get attention pretty quickly. You take in a code stroke, what happens? you're pretty much almost greeted at the door, okay, what do you got here? And they're attacking the patient. We need to have the same mentality with these sepsis patients because, like I said, this goes unidentified in almost 75% of EMS transports. And if we're not identifying these patients, what happens? They get to the hospital, you're just like, oh, she's had a cough. Okay, they're not gonna, if the vitals aren't terribly abnormal or anything, then okay, we'll get to the patient, they put them in a room, and now they're sitting there for half an hour, and they're sitting there getting sicker and sicker. Every second counts in sepsis, just as it does in a STEMI, just as it does in a stroke. So if we're able to alert and activate the facility that we're taking to, hey, we're bringing in a sepsis patient, okay, they're gonna be ready. They don't have to attack it as aggressively as STEMIs and strokes because it's more bedside care, but you know what? It lets the doc know, it lets the nurse know, and they're ready to go in there as soon as you drop the patient off, rather than half an hour later when they get caught up and they're able to get in there. So very important that we implement this and follow it through, because this is, I think this is gonna be the next big thing in which there's gonna be more aggressive time restrictions on how quickly we can deliver care to these patients, because $17 billion in costs is a lot of money. And I can guarantee you that's gonna be on the radar here pretty soon if it's not treated aggressively. So we need to keep that in mind. So this is our sepsis protocol, and I apologize, it gets washed out quite a bit on the projector, but I'll kind of read it through. The protocol basically emphasizes these three boxes right here. Right here in the middle is what you're gonna use to determine if you need to activate your patient as a sepsis alert or not. So the first thing is you want one item from box number one item from box number 2, and then 2 items from box number 3. Box number 1 is a list of risk factors, okay? It goes over things like, are they from the nursing home? Are they from a rehab facility? Are they from an LTAC? These are all places where high chance of getting a bacterial infection. Are they on dialysis? Are they immunosuppressed? Are they on chemotherapy? Are they diabetic? These are immunosuppression risk factors. Did they recently have influenza? Influenza puts folks high risk for developing pneumonia. So ask these questions. Do they have a splenectomy? Have they recently had a surgery or invasive procedure? Were they in the hospital recently? Have they had any kind of productive cough, diarrhea, fevers, any kind of change in their mental status? These are all risk factors that we need to ask about, okay? So if you have one item positive from this box, you move on to box number 2. And box number 2, it goes over some of the most common sources of sepsis, and you're gonna ask questions that would identify it. So you ask them, okay, any risk factors for pneumonia? If their complaint is cough, and they're short of breath, and they're having productive cough and fevers, maybe they've got pneumonia, okay? So that would be one. You ask them, is there an indwelling Foley catheter? Anything that's indwelling, Foley catheter, central line, PICC line, chemoport, these are all things that can become infected. So you want to ask about that. Are they having any kind of abdominal pain? Any risk for meningitis, headache, neck stiffness, any kind of chronic wounds? If they're diabetic, ask them about their feet. That's where diabetics can get bad infections in their toes. Take off their socks and shoes. Nobody likes to do it, but if you want to take care of your patients properly, take off their socks and shoes and look at their feet. And look in between each of their toes. These diabetics can get these terrible ulcers and they won't even know that they're there. So if you're the person that finds that diabetic foot ulcer that this patient didn't even know existed and half their toes falling off, I've seen it, and the patient never even knew because they have neuropathy so bad they don't know it. You just saved that patient's life probably, or potentially their foot or their leg. So keep that in mind. If they have a PICC line in place, high source of infection right there. So if they have one of these items as positive, you move on to box number 3. And out of box number 3, this is kind of more pertaining to our vitals. You need 2 of these items in order in order to continue on as a sepsis alert. So temperature greater than 100.9 or less than 96.8. Now I know a lot of people have come up to me and be like, well, you know that our thermometers, they're not very accurate and they don't work. Well, ask the patient. Maybe the patient took a temperature, checked their temperature at home with their thermometer, and a lot of times they'd be like, yeah, I've had a fever today. How high was it? It was 102.5 earlier when I checked it, but I took some Tylenol and it's kind of gone down. But ask the patient, they probably know. And sometimes if the patient just says, yeah, I've had a fever, well, how high was it? I don't know. You know what? You have to give them the benefit of the doubt, especially if they have one risk factor from box 1 and one risk factor from box 2. And they say, yeah, I've had a fever, I don't know how high it was, but I sure felt bad. I would count it, okay? The other stuff that we're gonna look at, heart rate greater than 90, respiratory rate greater than 20. Now some of you guys are gonna be like, well, that's every single patient we transport. Probably is, okay? But remember, this is sepsis, okay? So yeah, you have a broken bone, their heart rate is probably gonna be greater than 90, but they probably don't have a fever and cough and shortness of breath and or signs of an infection. So remember, it has to be a heart rate greater than 90 associated with suspicion of an infection going on, okay? So not everybody is gonna be a sepsis alert. They have to have criterion from box 1 and box 2, and that's gonna help you narrow down a lot of people on if you're gonna be calling a sepsis alert or not, okay? The other thing, acutely altered mental status, okay? In elderly folks especially, we see when they have a bad infection, they have a bad UTI, they become very altered. And as you treat their infection, all of a sudden they go back to normal. So altered mental status is listed there as one of those as well. Now keep that in mind, you know, altered mental status can be caused by a lot of things. Hypoglycemia, that's why up top we do a blood glucose check, okay? Make sure it's not a stroke, okay? So we need to get in the habit of making sure we're doing full physical exams so we can help pinpoint exactly what's going on with our patients. The other thing, systolic less than 90, okay? These are patients that they're in bad shape. Their blood pressure is less than 90, they're in bad shape, okay? They have an oxygen saturation less than 92%, you can probably count on they might have some sort of pulmonary disease going on there, pneumonia or something, but a lot of times they get sick enough, they're not gonna perfuse very well, so make sure you look at those. And the last thing we have here is end-tidal CO2 of less than 25. So end-tidal CO2 of less than 25 has been shown to correlate with a lactic acid of greater than or equal to 4. Now, those of you who don't know what lactic acid is, it's a lab value that we check in folks that are septic. If their lactic acid is greater than 4, they have an extremely high risk for dying, okay? And so end-tidal CO2 of less than 25 has been shown to correlate with a lactic acid greater than or equal to 4. Now, how are you going to check that? We don't have the nasal cannulas to check, yeah, but you can plug your little end-tidal CO2 hose in and put it in their mouth and have them breathe in and out of it a couple of times until you get a waveform and until you get a value, okay? If it's 35, great, you can take it out, thank you. If it's less than 25, okay, do it just like you would to get the measurement, and then you can take it out of their mouth and report it, okay? So these are the things that we're gonna look for. One item from box 1, one item from box 2, and 2 items from box number 3. Okay, if you meet all those, you're gonna activate a sepsis alert, you're gonna call the receiving facility, you're gonna let them know, I'm bringing in a potentially septic patient. And I've spoken to the ER medical directors at both UT Health Maine as well as Mother Francis, and they are both very interested in having us do this. So be sure we're doing our part in identifying these patients, starting treatment, and helping these folks, because again, extremely deadly, debilitating disease here that goes under-recognized too many times, and we've got to get better at it. So after activating the sepsis alert to the receiving facility, you obviously want to try to get IV access. You're gonna administer 1,000 milliliters of normal saline bolus, okay? If you have a hypotensive patient, hopefully that's gonna help, okay? If you don't, you need to give it anyway, because septic patients, like I was showing you guys earlier, need to end up getting 30 milliliters per kilogram of fluid once they get to the receiving facility. So make sure if you give a liter, let the facility know. If you started a liter and they only got 500, make sure you let the facility know. If you gave more than that, let them know, okay? If you have a very long transport, I mean, we're talking not you get the first liter in and now you're 5 minutes away, okay, you probably can just continue on. But let's say you get that first liter in and you're still 20 minutes away from the facility. At that point, you want to continue giving fluids, okay? But then we're going to start Levofed, and this is what the Levofed is down here. And there's I put a video out on the norepinephrine, on how to mix it up and how to start it. And there's a whole kit that they're putting on all ambulances that has the dosing charts and everything. So make sure you watch it if you haven't watched it, and implement it if you need to. But really important to remember, just because let's say you do start the norepinephrine, you don't stop IV fluids, okay? You want to try to get another access, and you want to keep fluids going, because these people are usually pretty volume depleted, and that's part of the reason why they're hypotensive, in addition to they've got a bacterial infection taking over their body. But these folks, you got to remember, they didn't just get sick right before you got there. It's not like a car wreck. These people have probably been sick for several days to weeks, and they've been slowly declining. And what do you do when you don't feel good? You stay in bed, you don't really eat, you don't really drink, you don't really want to get out of bed and take care of yourself. And that's another reason why these folks have such a large fluid requirement. And a lot of times it'll help you. So don't be shy about giving fluids, okay? So now we're going to move on to vasopressors. So on the last note about the norepinephrine, I had a lot of people come up to me and give me the old Levofed. Oh, what are we doing using Levofed? Levofed's terrible. That's Levofed. That's Levofed. Leave them dead. Levofed. You're not supposed to give Levofed unless you want to kill the patient, or and this is what I call the flat Earth syndrome. They also used to think the Earth was flat a long time ago, and they learned that it's not, okay? Levofed is the very same thing. Levofed had a very bad name before. It wasn't Levofed that was killing these patients. It was our lack of recognizing how sick the patient was and aggressively treating them. And then you had no choice but to start them on Levofed. And of course they died because we didn't do our part as far as treating them goes. So, we need to get caught up with the 21st century. Norepinephrine has been the vasopressor of choice for almost the last 10 to 15 years. Dopamine is highly out of favor at this point. May change again in another 10 to 15 years, but that's medicine for you, okay? Medicine is constantly changing, and we need to stay with the times. We need to stay with what's been shown to be proven and useful and helpful for our patients, okay? We can't get in the habit of, well, that's what I learned in paramedic school 20 years ago, so, that must be the same thing we're doing now. No, okay? Well, that's what we've always done for the last 15 years, so that's the way we need to keep doing it. No, that's not the right way to do things, okay? We need to do what's in the best interest of our patients and what research and studies have shown to be the right thing to do, okay? So how do vasopressors work? Well, they act on 3 different types of receptors. The alpha receptors, which are on your blood vessels, and the alpha receptors respond by causing vasoconstriction. They clamp the blood vessels down. You have your beta 1 receptors on your heart. They increase the heart rate and they increase the cardiac contractility. And then you have your beta 2 receptors. Beta 2 receptors kind of work in the opposite of alpha receptors. They vasodilate, and then they also bronchodilate, and they relax the uterus, okay? And these receptors are all working together. Your body is basically trying to maintain a perfusion to all your organs, right? And in order to perfuse your vital organs, you have to keep a certain blood pressure. And your heart and your blood vessels, they work kind of together in tandem to complement each other. So if your heart rate slows down, what's going to happen? Your blood vessels are going to constrict to try to maintain the blood pressure. If your blood vessels dilate, the heart rate is going to go up and the heart's going to try to pump faster to try to keep blood flow to these vital organs, okay? Does everybody understand systemic vascular resistance and how that works? How blood vessels clamping down increases blood pressure? Does that make sense to everybody? It's kind of like if you have a water hose, you know, if you have a water hose and the water's coming out, it's coming out nice and smooth and easy. Let's say you put your finger over the opening and you make the opening smaller. What happens? It comes out a lot more forcefully and a lot faster. It's basically the same concept with our blood vessels and our heart. So the first one we're going to talk about is dobutamine. Dobutamine is a primary beta-1 agonist and a weak beta-2 agonist. So I put this little chart down here on the bottom to kind of help remind you what the receptors do. But basically, dobutamine is great. It increases the heart rate and the stroke volume. It's going to make that heart squeeze and pump a whole lot harder, and it does mildly vasodilate your blood vessels, okay? You don't see as drastic of an increase in the heart rate as you do with dopamine. Dopamine will do the same thing a lot of times, but it can cause a lot more severe tachycardia than dobutamine does. So dopamine is, I know a lot of folks have come up to me about dopamine. Oh, dopamine. Dopamine is very out of favor, and this is some of the reasons why. So dopamine, it was thought to be good at one point. It has dose-dependent effects. At low doses, less than 3 micrograms per kilogram per minute, it activates dopamine-specific receptors in the kidneys and in your splanchnic vasculature. Splanchnic is your abdomen. And it increases blood flow to your kidneys and your intestinal tract. At moderate doses, between 3 to 10 mics per kilogram, it's going to stimulate mostly your beta receptors. So you're going to get an increase in your contractility, and you're also going to see a very big increase in your heart rate, but then it's going to vasodilate your blood vessels. Okay, so you got all cardiac effects here, nothing on the blood vessels. And then finally, when you get above 10 mics per kilogram per minute, that's when you finally get your alpha receptors, and that's when you'll see it start working on also improving the blood pressure and causing vasoconstriction. So you got a hypotensive patient, for those of you that like dopamine so much, you got a hypotensive patient in the systolic of 70s, you start them on dopamine. Does anybody in here start dopamine at 10 mics or greater? No, you started probably at what, maybe 3 to 5? So you basically, all you're going to do is increase their heart rate to 130, 140s. You're actually going to do the opposite of improving their blood pressure because you're going to vasodilate them. And you're going to actually decrease the amount of blood that the heart is going to be able to pump out, because let's say if the heart was pumping at 100 times a minute, now it's going to increase to 130, 140, and it's not going to have enough time to fill up with blood to push that blood forward to your organs. So you kind of didn't really help the patient much. And then finally, when you do get up to 10 mics per minute, now they're probably going to be in some tachyarrhythmia, and you know, you didn't do any favors for the patient there. So not so great anymore, is it? So dopamine, why dopamine is not favored, okay? 25% of patients that you start on dopamine end up with a sinus tachycardia in the 130s, 140s, 150s, which is not efficient, or they end up in AFib, okay? There's increased rates of arrhythmias as well as death in cardiogenic shocks, and we're talking VTAC, not just AFib. We're talking about VTAC in cardiogenic shock compared to Levophed. And then in septic shock, when you compare it to Levophed, there's increased rates of death. And the last thing for us, the dosing is more complicated. You're doing it in mics per kilogram per minute, so a lot of room there for messing that up if we don't do the calculations. So just remember, there's no hope with dope, okay? So let's talk a little bit about norepinephrine. I like norepinephrine. Norepinephrine it's very useful. I call it the Swiss Army knife of vasopressors. It's got great function in a lot of different types of shock, okay? And that's why I like it so much. It's a very clean vasopressor. So the main action of norepinephrine is on alpha receptors, vasoconstriction. It clamps your blood vessels down, okay? So it's gonna help your blood pressure improve. It also works on beta-1 receptors, so it's gonna increase your stroke volume, your heart rate. You're gonna get better cardiac output, okay? It's the preferred vasopressor in distributive shock and cardiogenic shock with hypotension, because it's gonna, if you got a cardiogenic shock, okay, you got a heart, it's not pumping very well, it's weak, it's failing. A lot of times if you fix that pump, you get the pump pumping properly, you're gonna fix their blood pressure as well. But let's say they're hypotensive, they're in congestive heart failure and their blood pressure is in the 70s, just fixing the heart may not be enough to get that blood pressure up. And that's when Levophed is gonna be great, because it's gonna improve your cardiac output, but it's also gonna clamp those blood vessels down to help you improve your blood pressure, okay? So I got a new saying for you guys, all you leave them dead Levophedders, how about use your head, give Levophed, okay? So epinephrine is the jack of all trades, the king vasopressor is what I call it, right? Works on everything, and man, it's gonna tear some stuff up, right? It does it all. It stimulates your alpha, beta-1, and beta-2 receptors. So you get it all. You're gonna get an increase in your heart rate, your stroke volume, your blood pressure is gonna go up, it's gonna cause bronchodilation, and there's not very many opportunities where you need all of that except in anaphylaxis, right? Anaphylaxis shock, this is hands down the best in anaphylaxis, and that's why we give it. Because in anaphylactic shock, that's exactly what you have. Your blood vessels are completely vasodilated, and your blood pressure's going down the drain. You're bronchospasming in a lot of cases, and your cardiac output starts decreasing. And that's why epinephrine works in anaphylaxis. Compared to dopamine, this is gonna skyrocket the heart rate even more. So, epinephrine, very powerful vasopressor. So why not just go straight to epi then? If it does it all and it's so powerful, why don't we just go straight to epi? So the reason we don't go straight to epi, because it also has a lot of complications, okay? Significant tachycardias and arrhythmias, right? What's everybody scared of when you're giving epi? You're gonna put them in V-tach or something, right? V-fib or kill them. It also, in the sick patients, it increases your lactic acidosis, okay? Causes hyperglycemia, makes people very, a lot of our patients are diabetic. We don't need them having elevated sugars, especially when they have bad sepsis or whatever. And it increases the metabolic rate for cardiac tissue, which is also not good, okay? We need plenty of oxygen to our heart. We don't need it to have to work harder and use up more oxygen in these sick people, because they're already not delivering oxygen very well. So usually epinephrine is added when you've already maxed out, norepinephrine, you've already maxed out all your other vasopressors. It's usually the last vasopressor that's added on in ICU settings. So you should probably call it leave them dead epinephrine, is what I would say. So phenylephrine. Phenylephrine is a neat one. It's purely alpha, okay? All it does is constrict your blood vessels. Why would you ever need that? Well, there's a couple of useful reasons to use it. One of them is when spinal anesthesia goes bad, okay? Spinal anesthesia can cause hypotension by basically dilating your blood vessels out, and they don't have a problem with their heart. They have a great heart, they're a young, healthy person, but the spinal anesthesia went a little too deep and now their blood pressure's bottomed out. Well, that's when you can put them on phenylephrine, and it'll clamp up the blood vessels until that anesthesia wears off, and you'll help them get through. Neurogenic shock, it's not favored anymore. It may have some use in neurogenic shock, but a lot of times in neurogenic shock, they're bradycardic. Yeah, everybody know what neurogenic shock is? It's when you have a trauma to the spinal cord, it knocks out all your sympathetics. So you have no sympathetic input on your response, so your blood vessels are all dilated and your heart rate is too slow. So phenylephrine's great, because it does clamp the blood pressures, but one of the side effects of phenylephrine is that it causes bradycardia. So it's not really favored anymore in neurogenic shock. Guess what it is? Anybody want to take a guess? Lead fed, there you go. Vasopressin. So vasopressin is kind of a different one as well. Vasopressin, it doesn't work on your normal alpha beta receptors. There's specific receptors, vasopressin receptors on blood vessels only. And vasopressin works by activating these receptors and causing a vasoconstriction. Works great as an adjunct to norepinephrine in septic shock, and it also works pretty good in GI bleeds because it constricts the splanchnic circulation and helps support the pressure if they're hypotensive, and it also may slow down some of that GI bleeding. And the reason you'll oftentimes see it in ICU patients that are really bad sepsis because you want to lower the dose of norepinephrine. You don't want people on vasopressors. They're not good things to be on. But you want to, if you want to try to get the dose as low as possible, you can add a little vasopressin to them, and then you'll be able to lower the dose of the norepinephrine and support their blood pressure. So let's talk about shock now, and we'll tie this all together. So shock is a state of circulatory insufficiency, creates an imbalance in the tissue oxygen delivery and the oxygen demand, causing dysfunction and organ failure and damage. So there's 4 types: hypovolemic, cardiogenic, distributive, and obstructive. Heart and, like I was mentioning earlier, the heart and the vasculature system, they work together to try to maintain blood pressure and perfusion to your vital organs, okay? So they're gonna kind of supplement each other. So the first one we're going to talk about, hypovolemic shock. This one's kind of the easiest one. You know, you kind of know if someone's bleeding to death in front of you, right? So what are the causes? Hemorrhage, first of all, trauma, capillary leak. So if you got a really sick patient that's third spacing a lot of fluid out into their belly or their legs, this can sometimes cause it. GI losses, if someone's been throwing up, having a lot of bad diarrhea for several days, and then burns, okay? We all know burns require a lot of fluid. It's because they tend to lose a lot of fluid through their injuries. So what does this do to the physiology? So first of all, you're losing all your volume, your blood and your fluids. So you have a decreased preload in your heart, right? There's less blood going to your heart because, well, it's not there, you lost it. So the amount of blood that your heart is putting out is going to be decreased now. So what happens if the heart's not putting out enough blood and the heart's not able to pump enough fluid out? Your blood vessels are going to clamp down. So you see increased systemic vascular resistance to try to maintain that blood pressure. The heart rate's going to go up because it's thinking, all right, I need to beat faster to try to get blood out. And you end up with a patient that has cool extremities, cool peripheries. You see them, their arms and legs, their feet, going to be kind of cool to touch. They're not going to be very well perfused because all that blood is being shunted to your kidneys, your brain, your heart, just try to keep the vital organs working. What do you do about it? So if they're dehydrated, burns, GI losses, you're gonna give them tons of fluid. If they're hemorrhaging, you're gonna give them blood. And then ultimately, you wanna stop the losses, okay? So cardiogenic shock. Cardiogenic shock is a problem with your pump, okay? AMIs, heart failures, that's when your pump is too weak. It can't pump blood as efficiently because the muscles are too weak. Valvular disease, that's when you're not pumping it efficiently because blood is going backwards, the valves aren't closing properly. Dysrhythmias and heart blocks, this is when you might get bradycardias, you get slowed down or you get too fast like an AFib or SVT in which the heart doesn't have enough time to fill up with blood to pump efficiently, or it's going too slow to pump efficiently. So what does this do? Well, you get decreased cardiac output, obviously, right? You get a weak heart, inefficient contractions, bradycardias. If you're too slow, you're too weak, you're not gonna be putting out a lot. So obviously your blood vessels are gonna clamp down, you're gonna get increased vascular resistance, which causes increased afterload. Oops. And that's not good for a failing heart, right? If your pump has to work a lot harder against clamped down blood vessels, it's not gonna work very well. So that doesn't really help our situation when we got cardiogenic shock. You're going to see increased preload because the ventricles can't work well. All that blood is just backing up and sitting in the ventricles. It's not able to completely pump it all out. And that's when you start getting edema in your lungs, you get swelling into your legs, and you're going to have cool extremities because, again, the blood vessels are clamped. They're trying to get blood to all your vital organs. So what do you do about this? Well, there's a lot of things you can do about this, okay? You want to improve your contractility and the cardiac function. So how do you do that? Well, if they're in a heart block or bradyarrhythmia, you can pace them, right? That's going to help get their heart rate up. What if they're a beta blocker or a calcium channel blocker overdose? You reverse it, right? Give calcium to a calcium channel overdose. Give glucagon to a beta blocker overdose. Dobutamine. Dobutamine is a great one for heart failure patients in which their heart isn't pumping and their blood pressure is not too low. It's going to increase the contractility of the heart. It's going to make it squeeze a lot stronger. It's going to increase the heart rate. And remember, it also has beta-2 receptor action, weak beta-2, so it helps dilate the blood vessels. It decreases the afterload, makes it a lot easier for the heart to pump. So real unique. You know, if your blood pressure is not too low, dobutamine works really well. Milrinone, that's one that you don't see very often anymore, but it also works by enhancing contractility. Levosimendan, I've never seen that one, but it's a great one. It's supposed to increase the heart function, and it helps improve blood flow to the heart tissue itself by dilating your coronaries. So that's a really neat one. Maybe we'll start seeing it, but I haven't seen it yet, nor have I used it. Dopamine. Dopamine is going to enhance contractility if you're using it between 2.5 to 10 mics. The problem, like I was mentioning with dopamine, is it's going to skyrocket your heart rate. And if you're pumping too fast, you're not giving those ventricles enough time to fill up with blood and pump efficiently. And now norepinephrine, Levophed, is actually preferred in cardiogenic shock. I think I saw something in AHA, they actually prefer norepinephrine because it increases your contractility and your heart rate, and it'll help clamp those blood vessels down and improve your blood pressure. So if you got a cardiogenic shock patient and their blood pressure is less than 80s, dobutamine might work, but they may be too hypotensive to which just dobutamine is going to fix it. You might need a little bit support to clamp those blood vessels down and get the pump working better. And that's why norepinephrine might be a better choice. So distributive shock. This is your sepsis, your anaphylaxis, and your neurogenic shock, right? Spinal cord injury. So sepsis, you're going to have, these patients are always tachycardic and their blood vessels are dilated. So distributive shock it's basically everything doesn't work right. Everything goes wrong. You know, all the other ones I talked about, you know, if your heart rate slows down, the blood vessels try to pick up the slack by clamping down. In this, everything is going wrong. For some reason, the blood vessels should be clamping and instead they're dilated. So you see decreased systemic vascular resistance. In sepsis, initially you do see increased heart rates and increased cardiac output. In anaphylaxis, everything is wrong. Okay, your cardiac output's decreased, your systemic vascular resistance is decreased, they're dying. And in neurogenic shock, everything is wrong because there's an injury to your sympathetics. They're not working anymore. So your blood vessels are dilated, you're bradycardic, you have no vascular tone. So you see in sepsis patients, you're going to see increased cardiac output initially. They're going to be tachycardic. The heart's going to try to make up for all the dilated blood vessels. But what happens is the dilated blood vessels are going to keep pooling all the blood. You get decreased return back to your heart, and eventually you're going to see decreased preload, and your heart's not going to work as well either if the blood's not coming back to it. Okay? So decreased cardiac output in neurogenic shock, decreased blood vessels, dilated blood vessels, and your peripheries are going to be warm because all your blood vessels are dilated. They're not shunting the blood to where it should be going to your vital organs. And this is why sepsis is so bad and deadly, because your body completely stops working in the right way. Okay? So how do you treat it? Fluids. You want to make sure they are properly hydrated with fluids. Second, norepinephrine. Third, vasopressin. Phenylephrine, maybe. Neurogenic shock, maybe if they're not too bradycardic, but nowadays neurogenic shock it's favored toward norepinephrine. And then in anaphylaxis, obviously epinephrine, like we talked about. So obstructive shock. Obstructive shock is, it's pretty easy as well. You got a couple of things here. Pericardial tamponade, right? Heart rate's up, muffled sounds, they're hypotensive. You see their neck veins are swollen because everything's backing up. Tension pneumothorax, you got an increased heart rate, short of breath, decreased sounds. They're hypotension and they're hypoxic, potentially. And then you got a PE, which can also cause obstructive shock, in which you got hypoxia, hypotension, increased heart rate, but normal lung sounds. Okay? So what do you get? You get decreased cardiac output, obviously. Something's blocking the heart from filling or from pumping forward. The blood vessels are going to be clamped down, trying to maintain blood pressure. Decreased preload, the heart's being constricted, so it can't fill up as much, like in the cardiac tamponade. And your peripheries are going to be cool. So what do you do about this? Okay, no, you need to fix the problem. Okay, pericardiocentesis, needle decompression, chest tube, the tension pneumothorax, anticoagulate the PE, get rid of that blood clot in the lungs. Okay. So let's go over some of the cases, and we're going to tie all this together. Okay, this is going to apply your shocks and the vasopressors, and let's make sure we understand everything here. So you got a 60-year-old male picking him up at a nursing home. The nursing home tells you, the patient's been short of breath, he's coughing, he's had a fever. They give you some vitals. His temp is 101.8, heart rate is 120, respirations are 25, your blood pressure is 70/45, and his SATs are 85%. Anyone want to take a guess on what this patient has? There you go, that's the right answer. No, but that is correct, right? So this patient sounds like they probably have pneumonia and septic shock, right? So based on our protocol here, you got your box 1 risk factor check, nursing home, okay? You got your box 2, they're having symptoms of pneumonia, they're short of breath, cough, fever. And then box 3, you got all these things checked. They have a fever of 101.8, their heart rate greater than 90, respiratory rate greater than 20, systolic blood pressure less than 90, O2 sat less than 92. This patient, slam dunk. Call the hospital, get going, okay? You're gonna start them on oxygen, put them on BiPAP if you need it, okay? Aggressive fluid resuscitation, get at least a liter going on them. If you got a long transport, you're gonna start norepinephrine. At the hospital, they may end up putting the patient on vasopressin as well. And most importantly, you're gonna activate the sepsis alert, right? Very good. So case number 2, we got a 75-year-old female, has a history of CHF. She's complaining that her legs are swollen, she's short of breath, and she's been weak. So you get some vitals on her. Temperature is 98.4, heart rate is 33. Respirations are 23, her blood pressure 85/60, and her oxygen sats are 90%. So on exam, your heart exam, she's bradycardic, there's no murmurs, it's a regular rhythm. Your lungs, you hear Ralls bilaterally. In your extremities, there's severe pitting edema to bilateral lower extremities. What do you think is going on with her? So you try pacing, doesn't really work well. Can't get good capture. Okay, so dobutamine, right? So how does dobutamine work? Remember we said it hits the beta receptors, right? So it's going to increase your heart rate, and it's going to improve her cardiac contractility, right? So dobutamine would go, and she's hypotensive, but not terribly hypotensive. You can certainly try it and see how well it does. And in this case, maybe it would improve. You get the pump working better, and the blood pressure follows. So good. So it's an acute CHF exacerbation with a bradycardia that's likely contributing to the fluid overload, the hypotension, and the volume overload in your lungs and extremities. She's moderately hypotensive and bradycardic, right? Hypotension probably from the decreased cardiac output. If we fix the heart, the blood pressure might improve with it. So we can start dopamine maybe, okay? You'll definitely improve her cardiac output and her heart rate will skyrocket, but it's going to probably put her at increased risk of becoming too fast, and you may not get the efficient blood pumping like you need, okay? You can start dobutamine. So dobutamine is going to improve your cardiac output and increase your heart rate, not as high as dopamine does, so maybe just the right amount. It doesn't vasoconstrict. It might actually cause mild vasodilation, but that might be actually good for this patient because now the heart doesn't have to beat against a clamped down vasculature. It might be able to contract a whole lot easier and get blood moving forward, okay? So this is decreasing the afterload might possibly help the heart pump more effectively, and you might see an actual improvement, even though it sounds like that doesn't seem right, but the physiology might actually help. It may not, but that's how, that's medicine. You have to try and see what happens. If it doesn't, lastly, we can always go to our good old Swiss Army knife, norepinephrine, okay? So you're gonna get improved cardiac output. It's gonna gently increase that heart rate. It's gonna, might not be as effective at improving the heart rate like dobutamine and dopamine are, but it's gonna help improve your blood pressure. And you'll see some improvement in the vasculature as well as your cardiac output. So case number 3, 23-year-old male complains of throat swelling, wheezing, chest tightness, short of breath, abdominal pain, started after he ate a cookie, and he has a history of a peanut allergy. So your temp, 98.7, heart rate's 120, breathing 30 times a minute. He's hypotensive, he's hypoxic, severe distress, tachycardic, he's struggling to breathe, wheezing, he's swelling in his throat when you look back there, and he's got a rash all over. What are you gonna do? Intubate? Anybody? No. Epinephrine, okay. What's the diagnosis? Anaphylaxis, okay, very good. That was obvious, right? So epinephrine, how much epi are you gonna give and where are you gonna give it? 1 to 1,000 or 1 to 10,000?
1 to 1,000.
1 to 1,000, right. So an anaphylaxis is 0.3 milligrams, in adults, 0.3 milligrams of 1 to 1,000. And 1 to 1,000 should only be given IM, not IV, okay? It's an extremely high concentration and you can cause problems. I know currently we have some discrepancies there, but that will be changing, okay? So 1 to 1,000 epinephrine should be given IM. And in anaphylaxis, you want to give it in their lateral thigh. IM, not sub-Q, not in their shoulder, not IV, IM in the lateral thigh. This has been shown to be the most effective place to give it, where it has the most rapid absorption, and you're going to get outcomes the quickest, okay? Also, you want to start IV fluids on them. Give them an albuterol treatment, open up their lungs as well. Benadryl and steroids, right? But epinephrine, utmost importance here. So case number 4, 27-year-old female, just had a C-section under an epidural, now has weakness and lightheadedness. Temperature is 98, heart rate is 80, respirations are 14, blood pressure 80 over 57, normal SATs. What do we got here? Spinal anesthesia, hypotension, right? What are you gonna do about it? Doesn't really have any problems with her heart though. You wouldn't be wrong, but there's a better option for this. Phenylephrine, right. So remember, the patient she's got a normal heart rate, right? And this isn't a spinal cord injury or anything. This is just an epidural gone bad, and so she's gonna have temporary vasodilation of her blood vessels. Sometimes they will get bradycardic too, she's not. So you could do Levophed, but you don't really want any cardiac effects. Her heart's working fine. If you do strictly phenylephrine, that'll give you your alpha effects, clamp those blood vessels down, and you'll get isolated improvement of her blood pressure, which is her only problem, right? Other than the epidural went wrong a little bit, but. So it's strictly a vasodilation problem. Phenylephrine works strictly on alpha. It's gonna increase your constriction and improve your blood pressure. No effects on your heart rate, which you don't want it to. In spinal trauma with neurogenic shock, that's when you get the bradycardia and hypotension because you have lost your sympathetics. And that's when your norepinephrine would be really good, because it would support that heart rate and the blood pressure. Phenylephrine might actually worsen your bradycardia in neurogenic shock, and that's why they don't use it very much anymore. So that's it. Any questions?